The knee, a complex joint designed to provide mobility and support for your body. Whether walking, climbing, or just sitting, physical activity wouldn't be the same without using your knees. A knee injury, however serious, can be treated, leading you on the road to recovery. Kneecap pain, or pain around the front of the knee, is the most common knee problem for patients coming in to see a physician, physical therapist, or athletic trainer. This condition is more common in women than men, and is especially common in the young woman involved in athletics or other demanding activities. Kneecap pain can also be common in older patients who have had heavy demands for many years, or old injuries resulting in chronic pain. Although some kneecap pain is seen as a result of previous trauma, most of the kneecap pain is caused by overuse, with no specific injury. The overall syndrome is known as patellofemoral arthralgia or chondromalacia and has several typical patient complaints. The patellofemoral joint is where the kneecap or patella slides in the groove or trochlea. The thigh muscles attach to the quadriceps tendon at the top of the kneecap. Below the kneecap is the patellar tendon attaching the kneecap to the tibia or lower leg bone. The thigh muscles in the front pull through the patella to the patellar tendon on the tibia, thereby straightening or extending the knee. The kneecap helps provide a lever, increasing the torque or strength created by the thigh muscles in extending the knee. The cartilage on the back of the kneecap and in the matching cartilage in the groove is a shiny white material, which is designed to be a low-friction, slick surface. This cartilage surface is surprisingly durable. It has to accept tremendous compressive forces during daily activities, including 1.5 times the body weight while walking, 3 times the body weight while climbing stairs, and 8 times the body weight just squatting down. Even greater forces are generated with jumping or direct trauma to the kneecap. There are several things that may contribute to kneecap pain. First of all, individual anatomy and genetics play a big role. The angle between the pull of the quadriceps and the pull of the patellar tendon is called the Q angle. An enlarged Q angle is associated with the increased risk of kneecap problems. Similarly, increased looseness of the kneecap, increased tightness in the outside soft tissue, poor muscle development, particularly in the vastus medialis part of the quadriceps muscle attaching to the upper inside aspect of the kneecap, and tight hamstrings and other thigh muscles are all known to contribute to increased risk of kneecap trouble. Certain shapes of the kneecap and the groove, and perhaps some mismatch in these shapes, may also predispose the knee to pain. Most kneecap pain is related to overuse. The repetitive stresses of vigorous activity or the repetitive strain from everyday tasks compounded over a long time may cause kneecap pain. These activities often involve running, jumping, stair climbing, or repetitive squatting and kneeling. Sitting with the knees bent for a long period of time will also aggravate the kneecap problem. Traumatic injuries or direct trauma to the kneecap may sometimes cause problems down the road. A typical example is the so-called dashboard knee, where a person involved in a motor vehicle accident strikes their kneecap against the dash, causing bruising and swelling initially. Then sometime after a delay of even several months, they will develop the kneecap pain. A direct fall onto the kneecap also can precipitate kneecap problems. Another predisposing factor is advanced age, because of the normal wear and tear of the joint and possible arthritic problems. The symptoms associated with this syndrome can vary widely. However, there are many elements that are common to patients. Often, both knees are involved to a varying degree. Typically, there is poorly localized aching pain, mostly in the anterior or front area of the knee. This can sometimes be sharp or burning, particularly for short periods directly after knee activity. There is often an associated sense of grinding, particularly with squatting or stair climbing. Occasionally, there is associated swelling. This is usually just below the kneecap on either side of the patellar tendon, but occasionally involves a true effusion, or fluid in the knee, with swelling above and around the kneecap in a horseshoe shape. In some instances, there are episodes in which the knee seems to give way, where people don't actually fall down, but have a sense of weakness or lack of confidence in the knee. Some may recognize difficulty rising from a chair or an inability to squat. Your doctor will perform an evaluation to determine whether this is truly a kneecap problem versus other problems with the knees, hips, or even the whole body. Also, the related but separate problem of patellar instability, where the kneecap actually slips out of the joint at times, needs to be ruled out. The patient history usually involves the patient's activities, physical demands, the nature of the problem, whether there was any initial traumatic event, the pain pattern, any associated swelling, locking, giving way, or other related symptoms. It is important for the patient to indicate whether they've had any old injuries or similar problems in the past. The physical exam may include observation of the overall alignment of the legs and the kneecaps, examination for motion, palpation to identify areas of tenderness, flexibility and strength testing, and special tests for the kneecap. Further studies may include X-rays of the knee. Typically, even more extensive studies would be considered only if the problem were particularly prolonged and did not respond to conservative measures, or if after the history and physical exam, the doctor felt that further tests were necessary to rule out other causes for the pain. The prognosis with conservative treatment is generally good. The rationale for treatment is based on the understanding of the natural history of patellofemoral pain problems and the generally recognized high success rate with conservative measures. There are several elements to the treatment that are found to be quite useful. Most kneecap problems are related to overuse and are unlikely to lead to serious problems down the road.
I'm going to check for a little pain here.
They are also unlikely to require any surgical intervention. Careful conservative measures are highly successful in helping patients reduce their pain and have little downside risk.
Okay, Amanda, we're going to check for some pain here.
Your doctor may recommend supervised sessions with a physical therapist or certified athletic trainer to assist you with your rehab program. Finally, surgery is associated with several problems, not only with significant expense and risk, but often surgery is ineffective for kneecap pain. In fact, there's a small possibility that surgery can even make kneecap pain worse. Conservative measures usually include activity modification, ice after activities, anti-inflammatories, and rehabilitation. The anti-inflammatories include aspirin and ibuprofen, which are available in several over-the-counter brands. The rehabilitation may include supervised physical therapy or take-home exercises designed to improve thigh muscle strength and improve flexibility.
All right, Amanda, now these are some exercises you can do at home. The first one is called the straight leg raise, okay? What I want you to do is just straighten out the leg, lift her off the table here about 6 inches, and hold for a count of 5 to 6. Now for the next exercise, Amanda will take a towel roll and simply slip it in just above the knee, extend the knee, and then again raise the leg and hold for a count of 5 to 6. And relax. Excellent. Now we're going to stretch the hamstrings, Amanda, and what I want you to do first in the sitting position is bring your left foot in the inner thigh area. Good. Hold your back nice and straight, chin up, knees straight. And I want you to touch your toes, maintaining that straight back, chin up. I want you to hold that for 30 seconds, okay? Good. Real good. 30 seconds.
Therapy may also include certain kneecap taping techniques or a neoprene kneecap sleeve. If there is a significant lower extremity malalignment, orthotics might be used when returning the patient to activities. Simple conservative measures include avoiding high-heeled shoes, avoiding shoes with no shock absorption, avoiding stressful activities for the kneecaps whenever possible, and taking frequent breaks during the day. Occasionally, despite the best conservative measures, the pain can be persistent and unacceptable, and eventually lead to the consideration for surgery. There are many surgical options that have been tried over the years, and none of them work a high percentage of the time. Often, arthroscopy is included, and may include scraping cartilage in the back of the kneecap. Sometimes a lateral release is done, which is basically an incision in the deep tissues in the lateral retinaculum, loosening up the kneecap on that side if it's too tight. A more aggressive procedure would be a patellar realignment, to change the overall alignment of the muscles, the patella, and the Q angle to change the forces on the kneecap. The surgeon and patient will usually enter into a surgical effort only after prolonged conservative measures and careful consideration. Most of these procedures are only helpful on the average of about 2/3 of the time, and often not the 90 to 95% that we would like to see with more successful surgical procedures. When they are helpful, they typically do not cure the kneecap pain, but rather just reduce it and make it more manageable. Nevertheless, it may be appropriate and may be helpful in certain cases.
One more time.
It is important to have reasonable goals and expectations regarding treatment of your kneecap pain problem. Generally, the main goal is to help you manage your kneecap pain. Basically, we're shooting for less pain, less often, and increased ability for the individual to treat themselves. It should be noted that some mild popping and grinding behind the kneecap with activities may not be a cause for alarm. This often does not correlate with either kneecap pain or significant problems down the road. One should be concerned